Hello, everyone. Welcome to week 14. You've made it to the final week of my lectures for this class. Week 15 is a reflection week, so you do not have to do any sort of, you don't have to listen to me. So based on the minimal feedback I got from y'all on what you would like for me to cover this week, it's on dialectical behavioral therapy. I've also elected to not have you do any readings for this week. So you can just listen to my lecture. My hope is that what you will also do is go to the Google Drive that I set up at the beginning of the semester. There are two videos that I would like you to watch that correspond with this lecture. So in lieu of reading about this approach, I would like for you to watch those two videos. They're about 30 minutes each, so about an hour of watching. So, like I said, we're going to talk about dialectical behavioral therapy, better known as DBT. So, we'll talk about where it came from, what problems it was designed to treat, the theory that underlies it, and what DBT actually looks like in practice. So, you can do this in individual work, skills groups, phone coaching, and then also we'll talk about the stance of the therapist. And I want to connect this specifically to adolescent and family work, since that's most often when we see the intense emotion and self-harm that DBT was created to treat. All right, so this is Marsha Linehan. She is the creator of DBT, and she developed DBT for people who were chronically suicidal and engaging in self-harming behaviors. Over time, it became the treatment of choice for borderline personality disorder because it combines two big pieces: cognitive behavioral strategies along with mindfulness. So think skills plus acceptance. At its core, DBT is for problems characterized by intense, rapidly shifting emotions that are hard to regulate. I also encourage all of you to really ask yourself like how you feel about BPD, borderline personality disorder. And I really encourage you to take a trauma-informed approach to it. Many of the characteristics that show up in individuals who are diagnosed with BPD is a trauma response. Okay, so this is the first video that I would like you to watch. So again, going into Google Drive, accessing this PowerPoint, just copying and pasting this link into your browser. You will gain access through Alliance Library, so make sure you're logged into the library. But before we talk about any techniques, essentially we have to understand the problem that DBT was built for. So this video is about borderline personality disorder. So again, coming from a trauma-informed lens, BPD is not manipulative or attention-seeking. That's the pejorative cultural view on it. And it is, BPD is the like one accepted or one of, it's the most acceptable diagnosis to have a negative response to and a refusal to treat in the mental health world. So, like, please don't be one of those providers. So, what Linehan tried to do was reframe BPD as a disorder of emotion regulation. So, the goal here for you is to hear from her directly about how she conceptualized BPD, again, or the clients who presented with BPD, not as difficult people, but as people in incredible pain who need a different kind of treatment alliance. So please check out this video and then proceed to the rest of the slides. Okay, so Linehan's biosocial theory says that BPD develops from the interaction between biology and environment. Some people are born more emotionally vulnerable. They react faster, more intensely, and calm down more slowly. On its own, that does not create BPD. The problem is when that temperament grows up in an invalidating environment. So, this is a context that tells the person you're wrong, you're overreacting, your internal experience doesn't count. And so, the back and forth over years produces an emotion regulation system that stops working well. So ultimately, this is the same model in visual form of what I just talked about. So biological vulnerability on one side, invalidation on the other. And between them is a transactional process that escalates over time. So the person gets more dysregulated and the environment gets more invalidating. So, what DBT targets is both sides. They teach the client new regulation skills, and then we also work to change the contingencies and invalidation around them. Okay, so Linehan makes this very specific. Emotionally vulnerable means high sensitivity, high reactivity, and a slow return to baseline. Invalidating environment means the person's private experiences are rejected, punished, or oversimplified. They get responses like, just get over it, you're too sensitive, or sometimes emotional outbursts are reinforced. So DBT assumes dysregulation is the logical outcome of that transaction. So we don't blame the client, we treat the system that produced the behavior. So, given that formulation, DBT has some fundamentals. We have to treat emotion dysregulation, we have to structure the environment, and we have to help clients behave effectively when they're overwhelmed. That means the therapy itself has to be structured and consistent because an unstructured therapy will just repeat the invalidating environment. Emotion modulation in DBT means 4 concrete abilities. First, inhibit behaviors that are driven by intense emotion, things like self-harm or attacking another person. Second, organize yourself to act toward a goal even when you're upset. Third, self-soothe the physiology, the body piece. And fourth, refocus attention when emotion is pulling you off task. DBT skills are literally built to strengthen these 4 abilities. So these are the 4 areas that are emphasized in DBT. So some of the fundamentals: an acceptance and validation of behavior as it is in the moment. So trying to eliminate the reaction to the emotional response. So you treat therapy interfering behaviors of both the client and the therapist, making sure that impasses are addressed, that the therapeutic alliance is very strong. There's the assumption that the therapeutic relationship is essential to treatment. You, as a therapist, are you are validating the client's experience in the goal of the client internalizing that validation so that they feel they are able to validate themselves as well. And then there's the dialectic process, so persuasive dialogue, a focus on reality. You'll see this at play in a video that I'll ask you to watch in a few slides. So Linehan said DBT has 5 core functions. We have to increase behavioral skills, so teach the person what to do instead. Increase motivation by changing reinforcement, so skillful behavior is more likely. Generalize skills, so you want to get them to use the skills in real life, not just in session. Structure the environment so the treatment setting supports change. And support the therapist, because this population burns out clinicians. If the program is missing any one of these, it's not full DBT. The D in DBT is dialectical. Dialectics is the idea that two things that look opposite can both be true. In DBT, the classic dialect is acceptance and change. The client is doing the best they can and they have to do better. We hold both at once instead of choosing one. The dialectical approach protects us from rigidity. We don't get stuck in the saying things like the client is resistant or the family is the problem. Instead, we ask, what truth is in the client's position and what truth is in the opposite position? Then we synthesize. This is hugely regulating for clients who live in all or nothing thinking. So the process is where we weigh contradictory facts or ideas and work toward a synthesis. So, for example, I can't stand this pain and I have to keep living. DBT helps the client find a way for both to be true. That's why validation and problem solving are paired in DBT sessions. The core dialect, again, is acceptance versus change. If we only accept, nothing changes and the client stays suicidal. If we only push change, the client feels invalidated and may drop out or self harm. So every session has to have both moves. DBT's overall goal is to decrease the behaviors that block progress, especially escape behaviors like self-injury, and to increase skillful behaviors. We target secondary problem behaviors, we build quality of life behaviors, and ultimately we help the client build what Linehan called a life worth living. That phrase is important. We don't just want the client not to die, we want them to want to stay alive. DBT has a very specific therapist stance. We balance unwavering centeredness. We believe in the client and in the treatment. And we also employ compassionate flexibility. We're willing to adjust when we're missing something. And we also balance nurturing style and a benevolently demanding style. We teach and coach, but we also pull new behaviors out of the client and don't do for them what they can do for themselves. That stance is part of the intervention. When we work with adolescents and families, DBT says, take a non-pejorative, non-blaming stance. We assume the whole family is in pain, parents too. Parents often feel shame, failure, and fear for the child's safety. So we talk about poorness of fit or invalidating behaviors rather than invalidating parents. We can even use genograms to show how invalidation is transmitted across generations. That lowers blame and increases acceptance. DBT skills are usually taught in 4 modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. Mindfulness is the platform. It teaches awareness and non-judgment. Distress tolerance helps the client get through a crisis without making it worse. Emotion regulation teaches them to change emotions before they spiral. And interpersonal effectiveness teaches how to ask for what you need and keep relationships. So this is another way to look at this. You can see the dialect of acceptance and change, acceptance on your left, change on your right, and where those 4 modules fall. So with acceptance, you're looking at mindfulness and distress tolerance. With change, emotion regulation, and interpersonal effectiveness. So you're holding all 4 of those at the same time to encourage that simultaneous existence of acceptance and change. So mindfulness. Mindfulness in DBT is not abstract. It's paying attention on purpose in the present without judgment. Clients with BPD often get swept away by past hurts or future fear. Mindfulness helps bring them back to just this moment, which increases control over behavior. This diagram is really central to DBT, the diagram of the wise mind. So the wise mind being at the intersection of both the reasonable mind and emotional mind, where the reasonable mind is more cool, rational, task-oriented. When you're in the reasonable mind, you are ruled by facts, reason, logic, and pragmatics. Values and feelings are not important. So tough to be fully in a reasonable mind. Think about this as like logic and emotion from Bowen's approach. And then the emotional mind is hot, it's mood dependent, it's emotion focused. When you're in the emotion mind, you are ruled by your moods, feelings, and urges to do or say things. Facts, reason, and logic are not important. So you can see like being in one or the other fully is probably not super helpful. And the balance of the two is important. Like the reasonable mind isn't better than the emotional mind. Neither is good nor bad. They just are. The goal in DBT is to be like governed by your wise mind. So this is the wisdom within each person. You're seeing the value of both reason and emotion. You're bringing right and left brain together, and this is considered the middle path. So you'll hear the term the wise mind a lot in DBT. Okay, so back to mindfulness. You will actually practice mindfulness in session. They're short, concrete exercises, things like observing the breath, noticing thoughts come and go, using the what or how skills that Linehan teaches. And repetition matters. The brain needs many reps to default to awareness instead of reactivity. So with teens in DBT, they hit classic dialectical dilemmas. They need independence and they need structure. They say, don't tell me what to do, but also don't leave me. DBT helps clinicians and parents not flip to one side, so not being overprotecting or not abandoning, but holding both autonomy and attachment. A standard DBT program is multimodal. It isn't just individual therapy, it includes individual sessions, group skills, between session coaching, and a consultation team for therapists. Each piece serves one of the DBT functions that we talked about earlier. Okay, so here's the actual structure. Individual therapy once a week for about 60 minutes, focused on the hierarchy of targets that we talked about earlier. Telephone skills coaching to help the client use skills in the moment. And then there's skills group. This is very structured, didactic. It's not a process group. And they don't let clients reinforce any self-harm by talking about it in group. So the idea is to make skillful behavior more likely in real time. Okay, so this is the second video that I would like you to watch. This is embedded in the PowerPoint slide. So you can see how one person conducts DBT. So this slide reminds us that clinicians adapt DBT to their own style. The core principles stay the same: dialectics, validation, skills, and hierarchy. But how you connect with your client may look different from how Linehan or any other therapist does it. Fidelity matters, but so does therapeutic fit. So please watch this video as well. So DBT is staged. The first stage is to get life-threatening and therapy-interfering behaviors under control. The second stage is to work on experiencing emotions without shutting down. So you want to replace that quiet desperation. Stage 3 is to address problems in living. So these are things like relationships, work, mood disorders. And then stage 4 for some clients is building joy or a sense of meaning. but we don't do deep trauma work until the client is, you don't do deep trauma work while the client is still actively self-harming. You want to earn the right to go deeper by stabilizing first. So with families, we mirror those stages. First, stabilize high-risk behavior and lower reactivity in the system. Second, improve communication and validation. Third, help the family support the adolescent's long-term goals. Again, dialectics, validating the teen and asking for behavioral change. So DBT always follows the target hierarchy. First, life-threatening or parasuicidal behaviors. These come before anything else. Second, treatment interfering behaviors, things like missing sessions, attacking the therapist, not doing the homework, or not removing lethal means. If we don't fix those, therapy can't happen. Third, quality of life interfering behaviors, things like depression, SUD, unstable relationships, homelessness. And alongside decreasing these, we increase the core skills of mindfulness, distress tolerance, interpersonal effectiveness, and emotion regulation. All right, so finishing y'all off here. So finally, DBT uses levels of validation. Level 1 is just listening without trying to change it. Level 2 is reflecting back accurately. Level 3, reading the unspoken emotion. Level 4, linking behavior to history, saying something like this makes sense given what you've lived through. Level 5, validating in the current context, saying something like your judgment here is sound. Then level 6 is radical genuineness. So you want to talk to the family like you talk to your own as equals. So we move up and down these levels to reduce invalidation and make change possible. And that's all I have for y'all today.